Without further ado, it's my pleasure to introduce Dr. John Sundy. He's the Associate Professor of Medicine, and he's in charge of the Rheumatology Therapeutic Area. And his topic today is going to be asthma. I know there's a lot of people who have asthma. Everybody knows somebody that has asthma. So we're very excited to have him, and I know it's going to be a great session. Thank you very much, John.
Thank you. Appreciate it. Thanks for spending your lunch hour here and probably delaying getting out of here today. It's impressive. We up? On or off? Is it? How about now? I can hear it coming through here. Can y'all hear it through the mic? Okay. All right. So I was asked to talk about asthma, and I'm curious, has anybody here worked on an asthma DCRI study in any way? Missy? What was that study? It's one we have not been able to get published, actually. So it's so to my knowledge, that's the only asthma project that we've done at the DCRI, and yet here we have this highly prevalent disease with many unmet needs, and should be an area that we ought to be able to really do well in. And so I would really like to use this as a way to get everybody hopefully thinking about what we can do to kind of get into this space, because we've got one of the premier respiratory pharmaceutical companies in the world in our backyard here. They have consistently wanted to work with Duke and have been frustrated to some degree about the amount of interest we've shown, and then not at the DCRI, and then, of course, we've just got a lot of resources to bring to bear. And so I thought what I would do is really just talk a little bit about the disease. I think that epidemiology, talk a little bit about the drug therapy of this, since that's the big bulk of what we do. And at that point, I think your eyes will be glazing over. And so we'll move into a little bit to more, just some resources at Duke, what we've been doing, what we have tried to do, because we actually have been very active in submitting proposals for asthma-related projects here, and then just kind of talk a little bit about the unmet needs. I would love to encourage you all to stop me and ask questions. I'd hate for this to just be a straight-out, kind of lecture here, so especially on a Friday. So anyway, so let's kind of kick it off. So I'll talk a little bit about asthma epidemiology and pathophysiology, talk about the pharmacotherapy, get into what I think is some really interesting research opportunities for us to get at the idea of response versus non-response. So we tend to, this asthma is a great area to show difficulties of picking outcomes and the fact that the vast majority of therapies fail in a significant proportion of people, even when they're approved and good drugs. And then to talk about some of the programs that we have ongoing at Duke and unmet needs and where we can go from there. So first of all, let's talk about what is asthma. And so I think an important way to look at this is that it really is a genetic and environmental disease. It's a gene-environment interaction disease. And while we know that's true for probably every disease that we take care of here, this is one situation where we have a much bigger understanding of the environmental impact than we do the genetic impact, but there's been a huge amount of research trying to investigate genetic etiologies of this condition. So while we know for, say, cardiovascular disease, there's a lot of environmental factors, diet, cholesterol, stress, whatever, smoking, all these sort of things, many of these factors come into play with asthma as well, too. And but trying to understand this interrelationship has proven to be difficult. And one of the challenges is the fact that we don't have clean endpoints like you do in cardiovascular trials where you die or you don't, or these kinds of things. So we have a much more difficult time, and I'll try to show you why in some of the studies that we look at here as well too. So the genetic factors certainly interact, and these can be a variety of things. The environmental factors in asthma can be infections. They can be allergens that we encounter in the environment, pollutants. And then we have this genetic overlay or an underlay, however you look at it, that is incredibly complex. And so some of these relate to a person's propensity to develop allergies. Do you develop allergies or not? Well, if you don't, your risk of developing asthma is much lower. But if you do, or if you are allergic, and that is you respond funny to things in the environment, then your risk of asthma is much higher. But you can also be allergic and develop allergic rhinitis, or you can be allergic and develop eczema or atopic dermatitis, or you could have an allergic tendency and develop food allergies. And so it doesn't necessarily have to translate into asthma. And so there's factors that are probably lung-specific that relate to whether you develop asthma. They have to do with the development of your immune system in life. And then there's a variety of other factors such as age that play into all of this. Occupation. So there's occupational asthma is a huge burden, and that's one of the more common reasons that adults will develop asthma over time, because most asthma actually begins in childhood. So let's talk about this. The other thing, beyond it being a genetic and environmental disease, is that it really has to be viewed as an exacerbating and remitting condition as well too, and yet it's chronic at the same time. And so this is one of the biggest barriers that we face in terms of asthma management, and that the vast majority of asthmatics are asymptomatic for most of the time that they are walking around. And yet they can have these rapid onset of symptoms that in a small percentage of asthmatics can even be life-threatening. And yet the underlying tendency, the underlying problem that we're trying to treat is actually chronic. It's going on all the time, but it can wax and wane. And so symptoms don't necessarily correlate with what I'm going to show you is inflammatory activity in the lung. And so this has some very difficult issues with regard to management and how we use and dose medications. And so if we were to take a corollary to say hypertension, where most people who are hypertensive all the time if they were not on medications. They might have peaks and valleys in their measurement of blood pressure, but for the most part they're there that way all the time. Or if you're hypercholesterolemic, you tend to be high within a certain sort of range as well too. But what we measure in asthma has more to do with symptoms, and it's very dependent on patient self-report of symptoms and assessment. We can measure lung function and other things, so we'll get into that in a little bit. So there's really three defining features of asthma, if you were to kind of think about the pathophysiology. And one of those is that you have inflammation of the airway, and I'll show you that. You have what we call airway hyperreactivity, and that's the tendency to develop bronchospasm, where your airways will narrow. And then the other key component of this is airway remodeling, and that is, you could view that to some degree at a general level as kind of a scarring or a chronic change that occurs over time, mainly due to this chronic inflammation that changes the character of the airway, changes how much it can expand, it changes its baseline narrowing, and can change the makeup of the cells that line the airway itself as well too. These same kind of changes can occur in people with COPD from smoking, and so that's another key component of that. So I'm just going to try to show some slides that might illustrate this to some degree. And some of this may or may not project particularly well, but if you were to look at this and consider this to be a slice through the airway, that you sort of took the airway tube and you just sort of cut right through it, and we're looking at it microscopically. This would be an example of what the normal airway is. So you have this 2 or 3 or 4 cell layer thick lining layer, the airway epithelial cells, and you have this very thin membrane that is kind of the foundation for those cells. And then underlying tissue that can occur. Compare this to somebody who's had advanced asthma. You can see that there's loss of some of the architecture of the cell population, and this pretty dramatic thickening of this basement membrane here. And this can lead to all sorts of problems in terms of how that particular airway functions over time. Yeah.
How long? This is the problem. One more time. How long would a person have an active disease before their airway would look like that?
Yeah, so that's a very good question. And so probably for most asthmatics, they won't develop this, but a subset will. And up front, we have no way of predicting who that may be. And so we know that if you were to do serial lung function measurements in asthmatics over time, year by year, over a 20, 25-year period of time, the normal age-related declines in lung function happen more quickly in asthmatics, but headed up front, this could be something that could develop over a period of 30 years in some patients, or others who have more aggressive disease may have this develop over a period of 4 or 5 years as well. So it can be highly variable, and many asthmatics may not remodel at all. They may not have enough remodeling to be clinically important as well. So there's some of the heterogeneity of this condition as well that makes it hard. Yeah. going to scare everybody away from me asking questions now.
Is it reversible? I used to have asthma, and I've controlled it for some reason, I think through exercise. But if I ever remodeled, is it reversible if you get it under control?
Well, yes, to some degree, but I think there's a certain degree of remodeling that may not get better. And so some of this thickening that we saw in the basement membrane up here, this submucosal thickening, some of that may not get better. But one of the hard things to sort out is that we don't really have a good way to go in there and actually take serial measurements of somebody's airway. So most studies that come from this kind of study can come from either autopsy studies or people who die in car accidents or things like that. And we can actually do some airway checks as well too on different people, but it's hard to get at the most critical part of the lung, which is further down. This is very far out in the lung, if you will. If you think about that branching airway tree, we're getting out to the small branches as well. So we don't know the degree to which that might get better. The other key component of asthma is the notion of airway obstruction. And we kind of grossly break down changes in pulmonary function to be either restrictive or obstructive. So everybody working on IPF-NET here is very used to restrictive airway disease, where the ability to expand the lungs is lost over time because of scarring and other changes. Asthma works the opposite way. So generally what happens is people who have active asthma symptoms actually have hyperinflation of their lungs. So they're getting air in, the air gets trapped, you have a hard time getting it out. And that's what causes the wheezing. You breathe the air in, you've got these narrowed airways, and when you try to breathe out again, that causes air turbulence that we would hear as wheezing. And so many people who are in the midst of an asthma attack actually have lung volumes that are larger than would be expected, and certainly would be larger than baseline for them at any one point in time. And it has to do with this notion of having trouble getting the air out. And so what's shown here are actually what we call flow volume loops related to doing pulmonary function studies. And so I bring this up just because it illustrates the fact that measurement of lung function is a key component in assessing a person's asthma and proving whether they actually have obstructive airway disease. And one of the unfortunate things is that many asthmatics never actually get pulmonary function studies performed. And so this is a capability that's not usually present in most primary care settings. And so in general, I think that we think that this method is underutilized. It's relatively inexpensive. It's not any more big deal than getting a chest X-ray on somebody. But it can provide very useful information in terms of measurement of airflow and documenting some of the changes that can be important. And so while the curves and what's on them is not particularly important, what is interesting to know is that, and this is a good slide, this bottom left panel shows what the normal pattern may be for a patient and what may happen when somebody's in the midst of an asthma attack. So you get this big scooping of this flow volume loop. And what is shown here is the effect of the bronchodilator albuterol, or which is the most commonly used rescue medication, in terms of improving some of this difference in airflow obstruction over time. And so one of our goals is to try to take asthmatics and either keep them from getting to this point or improve the quality of their lung function so it gets more close to that normal type of flow volume loop. We're trying to prevent some of those chronic declines over time. All right, so this is the physiologic measure. This is what we see from the physiology of airway function. And I think this is shown best in this set of slides here. And so these are CAT scans taken through a patient's lungs at varying levels of the airway. And the left upper panel starts with the largest airway, essentially the trachea, if you will. And the left set of panels, the left column shows the diameter before a bronchodilator like albuterol is administered, and then the right panel, the right column shows afterwards. So when you look in the large airways, you can see that they're roughly about the same, maybe a little bit of a change. But when you get out to the smaller airways here, you can see pretty substantial difference. And I think it's most striking here in the bottom panel. So you can see that this is this asthma patient in the midst of having an asthma attack. And after they receive a bronchodilator, you can see that tube is dramatically bigger. And it doesn't take very big changes in airway diameter to markedly improve airflow through those structures as well, too. So this is, you can see very easily this is probably 2 or 3 times the size it was before the bronchodilator was administered, and has a big impact on how that person may breathe as well. So that's the physiology part of it. Then I talked about airway hyperreactivity. So one of the hallmarks of somebody who has asthma is that they have twitchy airways, and so it doesn't take much to cause them to develop bronchospasm. And so you can envision the airways being a straw that might have a rubber band wrapped around it, in a kind of a spiral shape around there. And that rubber band has the ability to constrict. That's smooth muscle cells that line the airway, and through a variety of triggers, those smooth muscle cells can constrict, and that causes the airway then to contract, and that's what causes the airway obstruction. Some of this smooth muscle movement is just part of our normal airway physiology. We're opening and closing parts of our lungs all the time, depending on what we're doing, our level of exercise, whether we're sitting up, lying down, these kinds of things. And so the ability to regulate where air goes in the lungs is important. And asthma is just in some ways is just a very overactive response to some of what would be normal variations in airway tone. And so what's shown here is actually results of a test, what we call a methacholine challenge. But one of the things that we'll do to see if people have hyperactive airways is to have them breathe a drug called methacholine, which actually causes bronchoconstriction. And people who do not have asthma are able to breathe progressively higher doses of methacholine and not have any worsening of their airway constriction up to a certain point. Whereas most people with asthma have bronchoconstriction at much lower concentrations of the methacholine challenge. And so what we do is we start off with a very low dose of this. They'll breathe about 4 or 5 breaths of this drug in. The drug lasts for about 90 seconds. It has a half-life of about 90 seconds. And so they'll breathe the drug in. We'll wait for a few minutes, then have them perform a lung function measurement. And we measure how much air they can breathe out in 1 second, a measure called the FEV1. And then if they do fine, then we take them up to the next concentration, and the next concentration. We keep going higher until they have about a 20% drop in their airflow. And the concentration of methacholine that causes a 20% drop in your airflow is a measure of how hyperreactive your airways are. And so another key feature then of asthmatics is that they respond to a much lower concentration, or they have hyperreactive airways to a methacholine challenge. So this has a clinical application, but methacholine challenges also have a much bigger research application in trying to really demonstrate that a patient that you're saying has asthma truly has asthma. So many asthma studies will often require that you have a positive result to get into a clinical trial. Or one of the things that we'll do is to see if we have reversible airflow obstruction. Can you do this if we give you a bronchodilator? Do you have obstruction at baseline? And then if we give you something like albuterol, does your airway open up to a significant degree? And if it does, that's another way to demonstrate airway hyperresponsiveness. Then I mentioned briefly the remodeling, and I won't spend much more time going into this other than just to talk about that notion of thickening of the basement membrane and what can happen over time. So one intense area of interest in drug therapy of asthma is to determine whether our treatments actually prevent airway remodeling. And there's some data to suggest that they don't, which was disappointing to a lot of people. I think the jury's still out on this as well, too, but this is one of the key unmet needs in asthma drug research right now, is to identify agents that might prevent or modify airway remodeling. And then I just bring this up to talk about a wide variety of cells. Inflammation is a key part of what happens in asthma. So, and shown here are just cartoons depicting all the different kinds of white blood cell populations that can populate the airway and contribute to this whole inflammatory response. And so this is really the hallmark, and this is the key focus of our overall asthma management strategies for patients, is to reduce the airway inflammation, because we know that that is really the root cause of what's going on. In the absence of airway inflammation, you generally don't have asthma. And so this is really an inflammatory disease that has abnormal physiology attached to it as well, too. And so this is really where we try to target things. So what causes the inflammation? Well, it's probably the environmental exposures that we come across. And so there's some things that we encounter in the environment that all of us will develop an inflammatory response to. And an example would be a bacterium or an infectious agent. But most of us will not develop an inflammatory response to ragweed pollen. But if you are allergic to those, to that, then you will. And so anywhere from 50 to 90% of asthmatics are thought to be allergic to something. That they have an abnormal immunologic response to non-harmful things in the environment. And we can talk a little about that in some more detail in a minute. But it's really this tendency to develop this inflammatory response and our efforts to try to reduce the inflammation that is the foundation of our asthma treatment. I just want to move into a little bit of epidemiology of asthma because this is also incredibly fascinating, I think, as well, too. So this slide is actually showing the percentage of children in different population areas of the world who report wheezing symptoms, okay? So, and wheezing is a kind of the hallmark symptom of asthma. And so on the top panel, we're looking at 1960, the middle part 1980, and then the year 2000. And we're looking at two populations. The red line here represents New Zealand, the United Kingdom, and New York City. The green line represents Sweden, Germany, and Spain. And then the bottom line here represents a village in Kenya that was studied over a long period of time. So what's interesting here is that the percentage of wheezing children in the Kenyan village is less than 1%. And what's shown here, though, is the fact that they actually have high levels of allergic antibody present. But it turns out that much of that antibody is actually made to helminths or parasites. So parasite exposure early in life actually is a hallmark of growing up in this village and in many parts of the world. So this symbiosis between parasites and humans dates back evolutionarily forever. And it turns out it may actually be very important in how our immune system develops. And the absence of that exposure may be one of the risk factors for developing allergic disease in general. If you look at the prevalence of wheezing in a sort of a northern European population here, that's about 5 to 10%. And then getting back to New Zealand, the UK, and New York City, more than 20%. So more than 20% of kids have wheezing on some sort of regular basis. Now, not everybody who wheezes has asthma, but this is a pretty good population survey method to detect the incidence of those things. And so you can see that this has increased quite dramatically since 1960. All right, and so we know we can't change evolutionarily in 40 years, but certainly our environment has changed a lot. And so that's an interesting thing. So the first reaction everybody has, oh yeah, our environment's dirtier, it's cleaner, the air's bad. Well, in fact, the air in most cities actually in the world, certainly most cities in Europe and in the U.S. actually have much cleaner air now than they did 40 years ago. And so it's not soot, it's not many of those things as well too. There's a variety of factors. And so this is a list. It might be hard to read, and I'll go through some of them. But one of the things is that we spend more time indoors now than we ever used to. And we tend to live in environments that are very tight. So an energy-efficient home is a great place to just grow allergens, indoor allergens like crazy, dust mites, mold, fungus, this type of thing. So the number of air exchanges in a typical U.S. home now compared to 50 years ago is dramatically lower. Great for energy utilization, not good for kind of keeping the allergen burden low in the environment. We have much more dramatic changes in hygiene. So we have a cleaner water supply. We're exposed to far fewer infections early in life as well. We've eradicated most parasites that in Western Europe and the U.S. And the introduction of broad-spectrum antibiotics also to treat bacterial infections as well too really came to light in the late 50s and early 60s as well too. And so most people who were born after age 1960 actually grew up in an environment where they were treated. As soon as you had an infection, you were fired in there on antibiotics, and often didn't have a chance to develop immune responses to these agents in the environment. And then there's a number of lifestyle changes that have been hypothesized as well too. And so one of the key areas is that there's much more time spent in a sedentary state. So much more TV time, much more time in front of a computer terminal, not out running around as a kid at least. This also is associated also with the rise in the rates of obesity, and there's a very clear association between risk of developing asthma and obesity as well. And then also changes in diet as well too. So not all of which are quite understood at this point, but there certainly have been dramatic changes in the balance of fatty acids that we consume in our diet, certainly the types of sugars that we consume as well too. And then the other key thing that's gotten a lot of attention lately is the high prevalence of vitamin D deficiency in our population. And so we're indoors more. We're not drinking as much vitamin D fortified dairy products as we had been. So we have between that and less sunlight exposure, less vitamin D development. We're all slobbing on sunblock, going outside, things like this. And so we're not getting that kind of exposure. And vitamin D has been clearly associated with very dramatic changes in how our immune system develops over time. And so this is and we don't quite understand all the implications, but vitamin D deficiency has been associated with both autoimmune diseases and allergic diseases as well. And one of the research networks we're involved with now will likely be kicking off a vitamin D intervention trial to see if you can actually improve asthma outcomes in people who are vitamin D insufficient. So some estimates in the southeast would say that 25% of us have low vitamin D levels, and these can be people who are perfectly healthy. So I'm sure that a substantial percentage of us in this room actually have low vitamin D levels, which are risk factors for osteoporosis, in addition to a variety of other conditions as well. So these are some of the environmental things, and they're things that I think most of us would not typically come up with as risk factors for this. So, isn't it interesting that our environment may be too clean, that we have too little exposure to pathogens in the environment, that all the things that have been associated with this kind of Western lifestyle may actually be risk factors for developing allergies. And so one of the things that's actually been shown, if you grow up on a farm in Bavaria, where it's common for the farmhouse, to actually be built over the barn, and in that barn are cattle and everything, your risk of developing asthma is maybe half of what it might be if you actually grow up in a city in Germany as well. And so one of the things is that you have a much higher exposure to the byproducts of bacteria and fungus and other things in the environment if you grow up on that farm than if you grow up in the city as well too. And so this has a big impact on how our immune system develops if you are born into that environment as well. The other frightening thing that we had noticed really from the 1980s was that there was a rising trend in asthma mortality. And so dying from asthma is not very common. So the estimates here put the rate at about 15 per million asthmatics per year. But of course, if you're talking about 15-20% of the population, that can add up. But the absolute numbers really peaked out in the mid-1990s, somewhere around maybe 5,000 deaths per year, and in the U.S. over that time. And then recently has been declining. And some of this may actually have to do with a better use of controller medications for asthma. The introduction of inhaled corticosteroids to control the inflammatory response may be part of that factor as well. So the trend has been good over the last 10 years or so, and still trying to understand some of the mechanisms that may relate to that. And then finally, there's a lot of drug safety issues, and this is actually an FDA report that was posted yesterday, and this has to do with the LABAs, the so-called long-acting bronchodilator agents. And this has been in the press a lot, especially here in our backyard with Glaxo's Advair, which is got the drug salmeterol in it, which is a long-acting bronchodilator agent. And there have been some studies showing increased mortality in patients who have been on this drug. And yet it's been very hard to demonstrate, subsets of patients or understand mechanism behind this as well too. But this safety announcement that got posted yesterday really had to do with the fact that the FDA has decided that the LABAs should not be used as single-agent therapy for people. It should be combined with a controller therapy. And that once people's asthma is controlled, you should make efforts to try to discontinue that aspect of the drug as well. And we'll talk a little bit more about that as well. So there's a lot of safety surveillance issues that are very active in this condition as well. So this is where I'm going to kill you with some drug stuff, and I'll whip through this. And I don't really want to get into a big discussion of pharmacology here, but I think it's important to understand the different classes of drugs that are used, given our business here as well. So what is the therapeutic approach to asthma? Well, this is kind of shows kind of the pyramid that you might consider when we think about this. So, so shown along this lower axis here is kind of a assessment of asthma severity, and there's a lot of ways that you might define that. But we're working up the severity tree here as you go toward the right. And all of our therapy kind of builds upon adding on higher and higher intensity therapy depending on someone's disease severity. So certainly one of the first things when we suspect asthma is to make sure that we understand environmental triggers that could be going on, understanding patient activity, the kinds of things that they're doing, so that we can make environmental controls and provide education about symptoms as well too. After that, and the person who actually has intermittent symptoms of asthma, what we would call mild intermittent asthma, our routine therapy is fairly basic. We prescribe an albuterol inhaler, which is the standard short-acting bronchodilator available in the U.S., and we tell people to use it as needed when they have symptoms. And How often they need that turns out to be one of the key measures that we use to decide whether we want to intensify therapy beyond that. So the vast majority of asthmatics can do fine just with as-needed use of a short-acting bronchodilator. And so this might, if this is once a week or twice a week, then, we'll consider that reasonably good control of a person's symptoms. If they're not having activity limitations, they're not waking up at night with wheezing symptoms, then we'll go from there. We'll call that mild intermittent asthma, and doesn't really require more intense therapy. And again, this is, maybe half, maybe 75% of asthmatics that are in this category. But nobody stays in their little box of either, mild intermittent. People can move all over the map, and so it's a constantly moving target as well too. So if you were to say, okay, we're going to start a registry of mild intermittent asthmatics, and we're going to enroll them over the next year, and we're going to have 50,000 of them, a significant percentage of them will not be mild intermittent anymore if you go back to study them a year later. So you can't use that as a very rigid disease classification. After somebody develops more severe symptoms, what we would call persistent asthma, where they're having more frequent symptoms, that's when we begin to add on so-called controller therapies. So all the bronchodilator does is just regulate that airway tone and opens up or allows the airway to be opened up. After we begin to introduce controller therapies, we're really trying to manage the inflammatory response that's present in the airway. And the mainstay of that treatment are the inhaled corticosteroids. And so, corticosteroids are sort of the prototype anti-inflammatory medication. And one of the beauties of asthma is that that surface, the affected surface, is in contact with the environment and is accessible to us. And so huge amounts of work have gone into defining ways to actually get drug down into the lung to the right place in the lung so that it can actually be active. And so this requires having a drug dispensing device that delivers the right particle size at the right time in a person's respiratory cycle so that those particles of drug will actually get down to the right spot in the lung. It's a huge science that goes behind that. And most of the big players in that market are actually right here in the triangle, people with the expertise to actually figure out how to develop these devices and to create drug delivery in particle sizes that can actually get to the right part of the lung. So we will add those on the inhaled corticosteroids, and we tend to work up a dose tree. We push the dose as needed to try to control symptoms. Some patients will not respond to that by themselves, and they might need more systemic therapy as well. They might need oral corticosteroids. So there's a small percentage of asthmatics who are steroid dependent, we'll call it, who need oral medications, oral steroids to actually treat their disease. This is a very severe population. These are the people who are at risk of fatal asthma attacks and many of the side effects from that kind of long-term therapy as well. So it's really very much a step care approach, and I'll show you a page from the National Heart, Lung, and Blood Institute's Asthma Education and Prevention Program plan, which essentially provides a cookbook for clinicians on how to manage asthma. And you could do that as a clinician and probably be right 90% of the time in terms of managing most asthma patients according to that cookbook. And yet there's huge gaps in the quality of care delivered to asthma patients over time. I've talked about the so-called beta agonists or the bronchodilator. So this is the key approach. So this is the opposite of what everybody else has done here at the DCRI, talking about beta blockers. Well, here this is a beta stimulator. This is a beta agonist as well. So, so it actually good is the other way as well too. We're talking about different kinds of receptors that are present on the vasculature versus the smooth muscle of the lung. And they're actually selective agents. So the beta blockers are selective for the vascular beta receptors, and the drugs we use are selective for the respiratory beta receptors as well. So they have different functions as well. And we really have two drugs available in the U.S., albuterol and salmeterol. Actually, I take that back. There's actually a couple of new ones now, formoterol. But we have two long-acting bronchodilators, and we have about 2 or 3 short-acting bronchodilators as well. And so those are the SABAs and the LABAs that we talked about. All right? And so this actually just shows you, this is actually looking at airway function in patients who receive these drugs. So if you take an asthmatic patient, and what's measured here is the percent predicted lung function, or FEV1 that I talked about, and if you receive a placebo, you really have no significant change. If you get a short-acting bronchodilator, you can see you have a marked improvement in your lung function, and then over a period of several hours, it falls back off again. If you got another dose, it goes back up, and then it falls back off again. Compared to a long-acting bronchodilator like salmeterol, where your lung function improves, and then over that 12-hour period of time, it stays relatively stable or maybe normal. All right. And so again, this is the mainstay in therapy for rescue. We talk about rescue medications and controller medications. And rescue medications are the things that patients use as needed to try to treat symptoms when they occur. The controller medications are the things that we use to try to control the disease itself, the disease activity. And the whole beta agonist story, as I mentioned before, has gotten very complex because we have the short-acting and the long-acting. There's safety concerns about the long-acting drugs as well. There's concern about overuse of the short-acting drugs in lieu of controller medications as well, too. So a key component of this is patient education and trying to get appropriate medications into the right person at the right time. You have to be fairly talented to use these things. They come in inhalers, and the goal is to have people exhale and then to actuate this inhaler at the right time in the breathing cycle and then breathe the drug in and then hold your breath for 10 seconds to hold the drug in place to get optimal distribution. We tell people to use these spacer devices, which sort of hold the inhaler out at a proper distance to ensure that the right particle size has a chance of getting in the lungs. And so you'll see everybody walking around with that inhaler jammed into their throat and hitting the puffer, and most of the drug that they do is just going right on the back of the throat and just getting plastered right on there and never gets into the lungs as well, too. But who wants to be carrying this big, like toilet paper tube spacer around in their pocket as well, too? So there's a lot of issues related to compliance. Keep in mind these are kids, all right? And so, on the one hand, they don't like being stopped from running around, but on the other hand, who wants to carry this canister around with them? And so there's just a lot of issues that go into this as opposed to just saying, well, take your atenolol, take it every day, with breakfast, and you'll be fine. And so it's a real challenge as well. The corticosteroids, as I mentioned, are the mainstay controller medications. So these are the anti-inflammatories. We deliver them in the same way usually through a metered dose inhaler of some sort, through a device. And the whole goal is the same thing, is to get the right particle size of corticosteroids down to the distant parts of the lung to try to control this inflammatory response. So we like to use topical medications as opposed to systemic when we can for obvious reasons, for obvious safety reasons. And these drugs are very safe, but there's obviously people don't like steroids. And remember, there's a key distinction between the anabolic steroids, the Arnie Schwarzenegger steroids, and the anti-inflammatory steroids that we use. All of them have potential side effects with excessive use. But here we're delivering a small amount of drug to a very focused area, and the systemic effects are quite minimal. And certainly the benefits far outweigh the side effects. I'm not going to get too much into a mechanism of action for these drugs, other than to point out that we also can deliver these drugs orally, and probably many in this room have been on a steroid dose pack at some time in their life for a variety of different things. But the key thing is that we know that administration of these drugs can prevent exacerbations of asthma. So this is actually looking at exacerbation rates or symptom rates over a period of time in patients either started on a steroid or placebo. And you can see over a period of about 2 weeks that those curves diverge fairly significantly. This is with oral corticosteroids. We know that that oral steroids, the top line here, can dramatically improve lung function over a 2 or 3 day period of time, and that they can improve quality of life, prevent rehospitalization for asthma attacks, a variety of other parameters that are important as well. And so this is really a critical aspect of our management. Let me skip ahead and talk about another class of medication that's very popular, the leukotriene inhibitors. And so leukotrienes are a group of inflammatory molecules that are produced by white blood cells that can have very potent bronchospastic effects on the lungs. And so there's really 2 classes of drugs that are available to us right now to use. One actually prevents the production of leukotrienes, and the other actually blocks the way that leukotrienes bind to the receptor on cells as well. And so the prototype of the blocker drug is montelukast, which is marketed by Merck. Its trade name is Singulair, and probably very familiar to everybody. You can't watch TV or pick up a magazine without seeing an ad for those. And then Xylutin is another drug, trade name is Zyflo, for actually blocking the production of leukotrienes as well, too. These are oral medications, and they're generally well tolerated. They have modest effects relative to the inhaled corticosteroids, and so they're generally used as an add-on treatment. But they also have a big following in terms of use when people are not wanting to use steroids. And so a lot of times, especially in kids, if there's reluctance on the part of parents or the pediatrician to use an inhaled steroid, they'll often trot this class of drug out as well, too. Generally, certainly montelukast is well tolerated. It's dilute and actually can have liver toxicity. It requires regular blood tests to detect that. Yep.
Lately, these class of drugs have also been used to prevent asthma. Like children are being put on it if they show signs of wheezing.
Yeah.
So, I mean, what's the theory behind that?
Well, so you actually raise a really good point here, and that's the notion of preventing asthma. And it gets to the question of, do you have asthma? So that's the other thing, is that there's kind of this reluctance to trot out the word asthma in somebody who wheezes. And certainly in a child less than age 6, it's hard to know whether they are just a childhood wheezer or actually whether they are going to go on to develop asthma. After about age 6 or 7, it becomes pretty clear cut. If people continue to wheeze after that period of time, they have asthma. And so we have this whole kind of, nice word that we use, like, bronchitis, reactive bronchitis, reactive airway diseases, all these sort of things. Generally, that's asthma. And as I just mentioned, before age 6, kids can wheeze, and we can't figure out who's just going to be a wheezer or not. So that's probably the kind of scenario that you run into where the leukotriene inhibitors will be used in somebody who's wheezing. Generally, I think that from a disease treatment standpoint, we would view that as asthma until proven otherwise. Again, after age 6, a kid may outgrow that to some degree and go from there. So it probably is not changing the pathophysiology of what's going on. It's just managing the symptoms during that time, because the underlying tendency is going to be the same either way. It's not disease modifying is the important point. Yep.
Isn't there a difference, though, really, between childhood wheezer who wheezes with A and B versus your other childhood wheezer who wheezes with A through Z? I mean, aren't those fairly clear-cut?
Probably not. It's probably not clear-cut, let's put it that way. And so I think this illustrates the problem we face. And so a lot of times, in a 2-year-old, we don't have good ways of measuring lung function, so it's hard to demonstrate airway obstruction, for instance, by a pulmonary function study. And yet there are clearly kids who will wheeze. But if you look at, for instance, 2-year-old wheezers, if you're 2 years old and you're allergic, for instance, to dust mite or some other environmental allergens, your risk of having asthma at age 8 or 10 or 12, maybe 10 or 12 times higher than if you are a 2-year-old who wheezes, when you get a viral infection only and you're not allergic as well. So early on in life, the airway caliber is very small. Viral infection, for instance, we're seeing a resurgence of RSV, or respiratory syncytial virus, right now, and over the last couple of weeks, is a key cause of childhood wheezing. And so those viral wheezers are hard to sort out from somebody who will go on to develop asthma. But if you were to actually go and do skin testing on them, you could probably begin to stratify that risk of longer-term problems with asthma quite dramatically. So, but we don't typically do that, and most pediatricians don't typically do that. They manage the symptoms and you wait and see what happens, because we wouldn't really be doing anything different for these kids for the most part. Although there are some data now showing that if you're allergic and you have allergic rhinitis, if you start allergy shots early on in life, your risk of developing asthma can be cut in half almost, and so it's a pretty dramatic effect. Deciding that you're going to send your kid for regular allergy shots is a hard decision to make in that regard, though. So it turns out to be a very complex thing to try to sort out. And we don't know yet in kids how to measure somebody who's just an A-B responsive person versus an A through Z responsive person in very clear-cut, concrete ways. I think there's another question?
Yeah, I have a question. Can asthma be cured? I had asthma diagnosis and didn't go to PE classes in high school because of it, and then became a runner. And I think I cured myself of asthma sort of by using an inhaler and titrating it back, and now I no longer have asthma.
So let me ask you, how old were you when you started to have your symptoms disappear?
30s.
30s, okay. So the short answer is asthma can remit at any time in people, and so and it's hard to know whether certain things may bring that about or not. Right now, we don't have much confidence that any of our therapies actually cause that to happen. The pattern that you observe in yourself is something that would be much more common in teenagers, and so 15, 20, 25 years old to kind of grow out of asthma. and especially in boys. So boys are more likely to outgrow asthma than girls are, interestingly as well too. And we don't understand why that difference occurs. But the short answer is yes, it can remit.
There's another question back there. Oh, okay.
Does there have to always be a wheeze with asthma?
Yeah, that's a good question too. So the answer is no. Some people will cough. People will have symptoms of chest tightness. So those are sort of the three cardinal symptoms of active asthma: wheezing, cough, or chest tightness.
Okay.
And some people will have all three of those. Most will wheeze, but some people will just have symptoms of chest tightness.
Thank you.
Yep.
How common is it to develop asthma as an adult?
Just 1 second.
So how common is it to develop asthma as an adult?
Well, much less common to develop asthma as an adult than as a kid, but it still happens quite a bit. And some of this is just, if you sort of say, well, adulthood begins at age 18, and then we've got another, 60 some odd years, hopefully, to be exposed to things and develop asthma, that can happen. So a couple things you can say about adult onset asthma, that occupational exposures are a key risk factor for developing asthma, and in general, allergic asthma is a little bit less common with adult onset asthma than it is with childhood onset asthma, but still most adults who develop asthma are allergic. Most people, some would say 60-70% of people who are going to develop asthma have symptoms in childhood. Others will have entirely new adult onset.
It may be undiagnosed in childhood?
Well, and there's a high risk of undiagnosed asthma in childhood as well, too. So asthma is interestingly overdiagnosed and underdiagnosed in the population as well, too. So in the specialty clinics, we spend a lot of time undiagnosing asthma in people who are referred to us as well. So, other questions? Okay, all right. I'm going to come back to this slide in a minute. I'm not going to spend a lot more time talking about the clinical effects of this. I want to talk about another class of drug, and this is the omalizumab, which was the first drug that was a biologic drug that was approved for asthma. And this is when Missy Banks talked about the trial that we actually did here through the DCRI. This was a single center study that we did, but this was the drug that was used in this setting. This is an interesting compound. It's a monoclonal antibody. And the monoclonal antibody recognizes IgE. And IgE is one of our own antibody molecules. We have 4 key types of antibody molecules floating around in us: IgG, IgA, IgM, and IgE. IgE is the allergic class of antibody. And so, for instance, somebody who's very allergic to ragweed pollen will have high levels of antibody of the IgE type that recognizes ragweed. All right. What this particular drug does is actually goes around and essentially soaks up this IgE antibody. So if this is a IgE antibody molecule, and this could recognize cat dander, dust mite, ragweed, doesn't matter. It could be any of those things. The drug itself, omalizumab, goes around and binds this and sort of takes it out of play, so it can't be, so it doesn't function. And what it does is it actually prevents it from binding to a particular white blood cell population known as mast cells. And mast cells are the key things that get triggered to trigger an allergic response to something. So if you've ever developed a hive, it's because mast cells in that particular part of your skin got turned on and released a bunch of inflammatory compounds into the skin. It's what happens when you get a mosquito bite if you are somebody who itches when you get a mosquito bite. And so what this does is prevent this allergic antibody from binding on the surface of these mast cells, because it's that antibody binding on the surface of a mast cell that allows the mast cell to become activated when a ragweed pollen floats by somewhere in the environment. So it's kind of an interesting approach molecularly. This is generally reserved for more severe asthma, and it's expensive because it is a biologic drug. It has to be administered in an office setting as well too, by injection. And there can be some, you can actually develop an allergic response to the drug itself, which can include anaphylaxis as well too. So all of these things become risk-benefit trade-offs when you're trying to make decisions about how to use some of these drugs. Nevertheless, this can be a very important add-on to somebody who's got severe asthma, especially somebody who might be steroid-dependent and is suffering the known side effects of being on chronic steroids to control their disease. one of which can be in and out of the emergency room all the time with asthma symptoms as well. Theophylline is an old drug that's been used. People have heard of probably Theodore, things like this, but this actually targets some of the proteins that actually may, or some of the chemical compounds that actually may trigger bronchospasm as well too. This drug rarely gets used, but what it does is it actually inhibits a bunch of phosphodiesterase molecules. And PD phosphodiesterase inhibitors have had a lot of applications. Maybe some of you worked with some. They've had cardiovascular applications, allergy, arthritis, a variety of those as well too. So much of the pharmaceutical industry is working on trying to find safe and effective PDE inhibitors as well for a variety of clinical applications. I won't go into the chromones. People have probably heard of nasochrome or things like this. You can actually buy a lot of this over the counter now for anti-allergy drugs, but they stabilize mast cells and prevent their activity as well. And then I mentioned some of the other agents. So allergen immunotherapy has mixed results in treating asthma, but allergy shots is a great way to actually tolerize people to things that they're allergic to in the environment. So this is a key part of what we do in the allergy clinic as well. In people who, for instance, have bad allergic rhinitis or chronic sinusitis with allergies and they don't respond to medical therapy, allergy shots can be a very useful intervention for them as well too. And then we'll use some of the other immunosuppressive drugs, in particularly severe asthma, methotrexate, cyclosporin, some of the transplant drugs that we'll use. And then there's huge interest in developing inhibitors of a lot of the inflammatory cytokines that go along with this. So, for instance, in the DCRU, we've been doing work with an anti-IL-13 product that's been made in asthma, doing some early phase 1, late phase 1 and 2 work with these compounds. And hopefully that's something that we can carry over to here, if we can get a way to get in there. So what else do we do? Well, certainly environmental modification is important. Patient education is critical to this. I mean, you have to teach people how to use their inhalers, when to use their inhalers, when they're in trouble and they need to get to the emergency room, when they're not in trouble and don't have to. The importance of, trying to explain to people, no, this is your rescue medication, this is your controller medication. You got to use this one every day. This one you just use as needed. And then they come back in 2 months later, they're using the rescue medication every day, and they're using the controller medication as needed, and so it's a constant education process as well, too. Very tricky. And think about this, you're trying to do this across the spectrum of 6-year-olds to 90-year-olds as well, too. So a number of issues as well. Access to care is clearly an issue as well, too. So we certainly know that asthma outcomes are much more severe in the socioeconomically disadvantaged population. Much of this has to do with not being able to get medications or get into healthcare providers who can help put together a treatment regimen that's effective as well too. And then physician awareness is a big issue as well. So there's huge opportunities for knowledge transfer research to try to figure out how to take proven therapies and get them actually used when they're supposed to be used as well. So I want to spend a couple minutes just talking about this issue of response variation. And I want to really just show you a couple of key slides here. This is probably the best one among them. So this was a study where patients were in a crossover study design. They had active asthma symptoms, and they could have either been treated with an inhaled steroid, fluticasone, which is on this bottom graph, or montelukast, which is a leukotriene inhibitor as well. All right. And so they essentially took a bunch of asthmatics, and you could be treated for a period of time on one class of drug, and then you would be washed off, and you would cross over to the other class of drug and treated again. And so they went back and said, well, let's look and see how people did with each of these therapies here. And so what you look at this upper left-hand quadrant, these are people who responded to montelukast. And if you look at the lower right-hand quadrant, these are people who responded to the inhaled steroid. This one represents people who responded to both. All right? And then this is people who didn't respond to either one. And in this measure, this was actually a measurement of improvement in a person's lung function over time. And so you can see, I think, a couple of things that are interesting, that about 55% of patients didn't respond to either of those drugs by that outcome. And 17% responded to both. And then there's a group of people, 5% in the montelukast alone, and others in the fluticasone, or the inhaled steroid alone, about a quarter of them responded to just that one drug. But when you're sitting there in the clinic trying to work with your patient to make a decision, you have no way of knowing where that person's going to fall out. And so you could look at this statistically and say, well, look, I'm going to start you on this treatment, but I know that we have less than 50% chance that it's going to help you. And I have these two options available to me. And I think, and my greatest odds of getting a response to you are to give you the inhaled steroid. But I know that that's only, maybe about 20, 30% chance that you'll respond to that. Or it could be this other drug that I don't know that actually has quite a bit higher copay if you're going to have to use that one as well, too. And so this is not a good situation to be in. And so, and this is not unique to this. This is, you never see data presented this way, but this is true for every blood pressure and every statin and everything else out there as well, too. There's responders and non-responders, and we have very little knowledge about who's in which group as you move ahead. So again, this is something that I think is increasingly of interest to drug companies, but has been of far greater interest to treating clinicians as well, too. And I see this as one of our great opportunities of ways to actually try to sort this out. And many people here are thinking about those kinds of problems as well. But this is true across the spectrum of asthma medications available to us. And it's really, and the other thing that I shall point out here too, this is actually one other thing, that response to treatment can actually be variable. So in this particular setting, you're comparing responders between weeks 3 and 6 of a study versus weeks 9 and 12. And so this is kind of a scattergram. So if you are in this upper box here, you were a responder at both periods of time. If you're in this bottom one, you were never a responder. Or if you're in one of these side categories, you responded at one block of time, but not the other. So this shows you the variation in just the disease activity over time as well, too. It's probably not a loss of drug effect. It's just a change in asthma activity over time. But you can see how this might impact the time point that you pick as an endpoint in your trial may have very important implications for whether your drug is viewed as a success or a failure as well. And so you have to understand a lot about the mechanism of action of your drug and how it plays into response. So for instance, running a trial that cuts into, say, a high viral exposure season could torpedo a drug just because you had a high risk of other outside external stimuli that could have triggered asthma attacks in somebody. This may be particularly important in kids, if you're studying 5-year-olds, for instance, as well. So a lot of key issues there. I mentioned the guidelines that are available to us, and so these were last updated in 2007. And as I mentioned, you could use these guidelines without thinking and probably be right 90% of the time if you actually followed them to a T. And yet compliance with these guidelines is notoriously low in the general population, medical population. I want to talk a little bit about what we're doing here at Duke. So 4 years ago, we opened the Duke Asthma, Allergy, and Airway Center, directed by Monica Kraft, who is an internationally renowned asthma researcher. And we have, this is actually located in Ben Franklin Medical Park up near Durham Regional Hospital. And so we've had a chance to really grow our allergy presence as well. It's a beautiful setting, and it's free parking, and you can actually park right outside the door and walk in. And you can't really see it in this picture, but it sits on a big pond with a big fountain out there and back. And every now and then I walk outside to make sure it still says Duke on the door to make sure that's the case.
Some work for you?
And that's right. And everybody's blood pressure is about 10 points lower out there than it is in the rest of the place. And then, a fair number of clinical trials, site-based trials that we do are based out at the Asthma Center as well, too. We've been doing, a long time, we've been doing work on what had been the GCRC and now the Duke Clinical Research Unit doing a variety of different asthma studies, mechanistic studies, drug trials, and others as well. And I see this as a key strategy for us to move to attract early phase trial business and hopefully be able to carry that over into late phase clinical trial work here as well. This is just a partial listing of some of the people who are interested in asthma research here at Duke at a variety of levels, both adult and pediatric. So there's a big cadre of investigators, but almost all of our work has been site-based work to date at this point. There's a couple of asthma clinical research networks that are active, and I'll tell you that there's really two. There's the ACRC, sponsored by the American Lung Association, and then there's AsthmaNet, which is sponsored by the Heart, Lung, and Blood Institute. And we put in to be the coordinating center for both of those and didn't get them. So, so that's again where our opportunity is, and I think maybe our challenge as well too. We're a part of both networks. We've been in the ACRC as a site since its inception in 1999. And then AsthmaNet actually represents a combination of a pediatric and adult allergy clinical or asthma clinical research network that got merged together and is just getting restarted again too. We are also a site in this network as well too. This one is Monica Kraft directs this one, and I lead this site here at Duke and this one as well. So this one is just this will definitely be successful. It is the sort of marquee heart, lung, and blood asthma research program as well too. And the ACRC site has actually been very successful as well too. We've had some very high-profile publications that have come out of this. The coordinating center is Hopkins for this, and I have to say they've done a phenomenal job of leading this network as well. And but we've done some key work looking at the safety of flu vaccine in children with asthma, looking at a randomized strategy for different treatment approaches or step-down therapy after somebody's achieved good control of their asthma symptoms as well too. And most recently, published just this last April in the New England Journal, is a study looking at proton pump inhibitors. So it's become fashionable to use proton pump inhibitors because the thought has been that reflux has been a key contributor of worsened asthma symptoms. And so if you are a kid or an adult and you're being treated for asthma and you're not getting better, there's a very good chance you'll get put on a proton pump inhibitor to slow acid production. And so this was a trial called SARA, and looked at that strategy in poorly controlled asthma, and it didn't work. And proton pump inhibitors are very expensive drugs, and they're the bane of pharmacy benefit providers because everybody's on them because everybody has heartburn at some point or other. And we are about 80% enrolled in a similar study in children as well, and I imagine we'll have the same finding in that particular setting as well too. So hopefully those will be guideline-changing articles or research that has been done through the ACRC. So this is just a partial listing of some of the unmet needs. We certainly are still in need of better therapies. We need better ways to deliver drugs to people. We need to find ways to actually prevent asthma, to actually get at the question you asked about the leukotriene inhibitors. Can we actually prevent the onset of asthma? We need to figure out ways to get clinicians to use best practices better, for sure. We need better diagnostics because we still have a lot of uncertainty, and we're still not sure which outcome to use. Should you measure a lung function outcome? Should it be a quality of life measure, an asthma symptom score? We end up using a lot of these things, and you end up picking one as a primary endpoint and hoping that that's the right one for your particular product. It's a very heterogeneous disease, and so we don't know how to subset those diseases, those subtypes of the disease effectively to select better therapies. So the whole personalized medicine notion is a great opportunity as well. And then to try to figure out how to do population-based interventions. And so a study published in the New England Journal last year actually had people walk through, people with asthma walk through a park in London during times where the diesel particle load was very high, and versus times where the diesel particle load was very low, and looked at differences in lung function over time. You could clearly see key changes. We've seen this in the literature before. It pertains to cardiovascular disease as well as respiratory disease. If you live within a mile of a highway, your risk of dying of a heart attack is much higher than if you are beyond a mile of a big highway. And this plays into asthma outcomes or COPD outcomes as well too. So there's clearly interventions that we could be making at a population or community-based level that might have important ramifications for asthma outcomes as well. So it's a different way of thinking about trials, but there's an opportunity as well. Really, I think that we have all the tools to do this. What we don't have is a track record of working in asthma, and the question is how do we kind of penetrate that space and own this, essentially. I just don't see why we can't. And the DCRI, that is. And I think there's lots of opportunities. I think some of it's just going to be persistence, but hopefully we can revisit this in 5 years or 10 years, and hopefully we're players in this particular game. So I'll stop there and see what other questions you have. Linda.
Okay. So my question is, I learned a lot. So I learned that asthma basically diagnosed, thank you so much, with low SES and obesity, genetics, environment. Okay. What I'm really interested in knowing is when you look at people who have asthma, specifically adults,
right,
and you look at race, when you subset on that, what do you see in the United States?
Right.
And then within the race, can you basically see, is it more men versus women? So tell me about race.
Yeah. So one thing that's very clear is that asthma outcomes in African Americans are poorer than they are in non-African Americans, and that can be measures of frequency of hospitalization or emergency room visits. It can be measures of lung function, so a variety of parameters. And yet, and there's a variety of causes that can be, I think, very definitively associated with that. It can be anything from, for instance, changes in the amount of allergic inflammation you get to a particular exposure, for instance. So there are some things that just how people respond to the environment. But it's also access to care issues. It's differences in living environments as well too, and it could be even differences in exercise levels and things like this. So these have all been investigated. I think you can see differences, and what we don't know is how to correlate any difference with causality to understand mechanism itself. And then we see also more severe asthma outcomes in Hispanics as well too. So there's clearly some differences. And I think that they both relate to a variety of both environmental and genetic factors as well too. So we also know, for instance, that normative values for lung function are different if you compare an Asian or a Caucasian or African American populations as well too, in terms of what the normal range is. They're quite different. And yet, having been involved in a variety of asthma genetic studies where we've been actually ascertaining families, it's obvious, as we all know, it's very difficult to actually ascertain race or ethnicity as well too. And so, if you can go by self-report, how do you account for all the variety that there is, in the population as well too. And so part of this too is that I think we're making blanket groupings that may not really apply because they actually may be more important factors. So, for instance, we've heard at times here from Marilyn Miranda in the School of the Environment from the Nicholas School here, who is very into geocoding and actually looking at very zip code specific changes in health outcomes. And if you take a geocoded map of say Durham and you overlay that with asthma visits to the emergency room, you can clearly see pockets that track by socioeconomic status. You can see pockets that may relate to proximity to known pollutants in the environment as well too. So all of these things play into it, and I think that to me it's one of the fun things about asthma is that it doesn't just happen in the clinic. Actually, to really understand this disease, you actually got to get out to where people live and work and do what they do. And so that's going to be the key in my mind to understanding this difference. But there's clear disparities. I don't know if that answers all your questions. Oh, and then the men and women. Depends on who you look at. So as we talked about, kind of early on, girls generally have more asthma and they're more severely affected when they have it. Boys tend to outgrow it during adolescence more often than girls as well too. That tends to change around a little bit. But we also know that asthma is probably underdiagnosed in older women as well. And again, I think it just doesn't get thought of, interestingly.
Can you talk a little bit about really what causes asthma hospitalizations?
Yeah.
What specific symptoms leads to that?
Sure. So that's a good question. So for most people who get hospitalized with asthma, the reason they show up is that they're having such severe respiratory distress that they're essentially worried they're going to suffocate. And so the common thing is to you can try this next time you're out, is to try to breathe through a straw, and then you understand what it's like to have a very severe asthma attack. And so that's what will bring people to the emergency room or have to call 911. And most people who present in that state to the emergency room can actually be treated and kind of turned around in the ER and sent home as well too. And that usually is with very aggressive use of these bronchodilators, treatment with steroids, and a lot of respiratory therapy over a 4 or 5 hour period of time in the emergency room. A subset of those patients will require hospitalization because they don't turn around, and then a smaller subset will have attacks that are so severe they require intubation to maintain adequate air movement. And it's in that population who have been intubated there's the highest risk of death due to an asthma attack. And what happens in those folks, usually it appears that what happens in addition to the airway constriction is that you get a lot of airway mucus production. So this is not unlike when you have a cold, and it's amazing how much mucus your nose can make, when you have a cold. Well, this is happening inside your lungs as well too during an attack. And probably what ends up killing people with asthma are mucus plugs that block off substantial part of the airway. You have this bronchial tree, and all this mucus kind of accumulates, just trying to get up, and then it creates a big plug in the airway, and that can actually lead to respiratory failure as well. So what we don't understand is why some people have asthma flares that don't really get severe, and others can have very severe attacks with severe bronchospasm as well in similar environments. The other thing I didn't really talk about, I just want to say, is that you can't underestimate the impact of tobacco smoke on asthma risk and severity as well, too. I mean, that's just a huge thing. In fact, if your grandmother smoked, your risk of actually developing asthma is higher. And that is probably due to epigenetic things, changes in levels of gene expression for certain genes that actually get transmitted across generations as well.
Yeah, because every once in a while you read in the newspaper that some 16-year-old went to a Sweet 16 party, they were smoking, and the person actually died.
Yeah.
And when I actually did some asthma studies for Glaxo when I worked for them, I saw a lot of pediatricians and pediatric allergists who said if the parent's smoking considers it child abuse in the house with an asthmatic child, he says he's going to call social welfare. So it's actually right. I was glad you mentioned it because it's an important trigger.
Yeah, it is. It's almost so obvious that we don't even bring it up, but it's critical to that.
Are there any other questions for Dr. Sundy? So thank you very much, Dr. Sundy. That was great. That was a fabulous presentation. Very important topic.